So today I want to start a discussion around labels. Not just how we label others, but more so how we label ourselves. As adults, we love our labels, and we cling to them because they make us feel comfortable. The problem is that sometimes our labels prevent us from seeing everything we're capable of. As children, we don't really label ourselves as anything. We're astronauts one day and cowgirls the next. We're made of pure creativity and curiosity at that point in our lives. And then we grow up and something changes. Whether due to societal pressure or our own visions of our ideal selves, we start looking for a box to put ourselves in. I've spent my entire adult life trying to put myself in a box. The pharmacist box, then the emergency medicine box, then the educator box, each with its own label and set of rules and constraints. I've put myself in a box, in a box, in a box. I'm lucky, though, that I've had a clear vision of my goals and I've achieved them. But no sooner had I achieved my goals that I began to feel restless and started to look for ways to get out. So I've spent the past few years working to do just that, trying to unburden myself of the labels that I have let constrain my thinking. Now, don't get me wrong, the box is important, especially as you learn something as critical and complex as caring for another human being. But it's easy to forget your many other talents as you focus so intently on mastery of just a few. So how do we rediscover our talents and allow ourselves to make room for creative endeavors? For me, I had to go back to my origins. If you would have asked me to define myself as a child, I would have definitely said I'm creative and I'm curious. Asked me again in college, I would have said I'm a pharmacist. Well, today, I'm pretty much back to saying I'm creative and curious. And that shift in how I see myself has been a small but important step in my growth as I work to realize my full potential. Looking to the past, where would we be today if our predecessors had allowed labels to define them? As Ralph, talked about Dr. Albert Benjamin Prescott, the namesake of this lecture, he's now regarded the founder of academic pharmacy. But at the time, he was labeled as a dissident and a maverick. Dr. Prescott was denied delegate status at the American Pharmaceutical Association meeting in 1871 because his new school at Michigan didn't meet criteria to be a school of pharmacy. Up until that point, as Ralph said, there were just one-year finishing schools for apprentice pharmacists. Dr. Prescott realized that few apprentices can become better than their teachers, and knew that for advancement to occur, the profession of pharmacy had to become a scientific endeavor and not simply a trade. The school at Michigan was the first to do away with apprenticeships and offer advanced degrees in pharmaceutical sciences. And despite a great deal of opposition from the pharmaceutical organizations, Dr. Prescott didn't back down from his stance, and he instead persisted to make his vision become a reality. And in 1885, Dr. Prescott ended up being elected vice president of APHA. Here's the amazing part, which I was kind of surprised to find out, was that Albert Prescott wasn't even a pharmacist, right? He was a physician. And he had a vision that changed the path of an entire profession. Imagine if it weren't for the persistence of this one individual and his irreverence for traditional labels and dogma, what would our profession look like today? Jump forward more than 100 years, and one of the best part about getting this award is that it gave me the opportunity to explore the achievements of the previous honorees. And having read about their work, I'm humbled to be in their company and inspired by each of these individuals who are blazing unique paths within the profession. It was incredible to read about Afton Wagner, a policy advocate for the profession and a leader in HIMSS, one of the most exciting healthcare organizations out there. Joshua Newmiller, the awardee from 2016, labeled himself for the pharmaceutical industry until a diabetes diagnosis changed his perspective and led him to dedicate his career to the education and advocacy for patients with diabetes. In Alex Adams' lecture, he introduced us to a new term, permissionless innovation, referring to the need to change the legalese defining non-physician scope of practice to leave room for critically needed innovations in pharmacy practice. Dr. Adams is championing this as the director of the Idaho State Board of Pharmacy and has led public health programs for NACDS and election campaigns for state senators. Lastly, I'll mention Sonic Pistachia, who felt extreme guilt after spending a month on medical mission in Kenya and has spent the last 10 years living there and directing educational programs that benefit Kenyans just as much as the people who travel there from the United States. Now, sometimes it's easy to be pessimistic about the boundaries of our profession, but looking at these leaders as an example, it's incredible to see what's possible. Each of these young leaders didn't allow themselves to be stymied by traditional labels. They're trailblazers and innovators, pharmacists who use their unique talents to have impacts far beyond the reaches of the pharmacy profession. And even so, it's hard to shake traditional labels. Despite individuals like these and countless others pushing the boundaries, your average person today rarely understands the breadth of the roles pharmacists play in our society. So, and worse, student pharmacists often have difficulty visualizing themselves outside of a traditional pharmacy model. So how can we change this? How can we change the labels that are applied to pharmacists? Let's think about this while we watch a short video that I think will get you thinking a little bit differently about how we can make a unique impact in our community.
Every big invention starts off very small, and then it just turns into something wonderful.
Starting off small and turning into something wonderful. That's exactly what happens at the Comcast Collaboration Studio, a program that joins existing partners with Comcast technology for the benefit of an entire community. In the first phase of the studio, Comcast brought together medical students and experts from Thomas Jefferson University and the University of Pennsylvania, middle schoolers from a program run by Philadelphia OIC, and the educators from the Food Trust.
For the medical students, it's a great opportunity for them to go into the community of Philadelphia and really impact the community.
Technology can be intimidating, and participating in this program is showing them that it's not as intimidating as you think. Food Trust comes in and they make it really fun and it's really informative, and it's also a great lead into the design activities we do with the kids.
And by source, we just mean a place where you can get food.
I definitely tell my mom that I want her to buy more fruits rather than chips and stuff. I'll see someone walking down the street and they'll have a slice of pizza. I'm like, why do you have that when you can have an apple?
I haven't picked a career choice yet, so learning about this career makes me think a lot about maybe I want to get into this, maybe I want to get into that.
Tina may or may not become Philadelphia's next great engineer or food scientist, but right now this collaboration is offering her the opportunity.
So when we think about the partners that are working on this project with us, they all have similar objectives, and what a great opportunity for Comcast to provide a platform where they can collaborate. But what's really exciting is the opportunity to actually be able to replicate this success, not just here in Philadelphia, but potentially other markets.
Other children should have what I have, the ability to come to this program every week. I guess it's like having a mentor, I guess, because we come here, talk to our one person who helps us with building, and it just feels like we're learning a lot.
What will your collaboration story be?
So how I got here is a question that I'm frequently asked by my students, realizing that I've taken a pretty abnormal path to where I am today. For example, how did I get into academic emergency medicine with no formal residency training? And how am I now teaching design thinking and 3D printing to doctors? I could answer that with one word: curiosity. And it all started with a narwhal. Seriously. So I remember like it was yesterday. I was in second grade and I had to do a report on something, and I was flipping through an animal book and I saw this crazy looking sea unicorn. I couldn't resist. I had to learn more. The issue is that this was the early 90s and there was no internet, and I didn't get far with the Encyclopedia Britannica. It was so hard trying to find information about this elusive creature, and I remember questioning why I had chosen such a weird topic. But when it was all said and done, it felt awesome. And this was the first time I remember being compelled by my curiosity, overriding my better judgment, and it's become a trend throughout my life. Curiosity helped me again in two significant ways when I was looking for my first job. Like many others, I entered my clinical year having no idea what to do with my life. And despite exploring opportunities with the military and then pharma, I was panicking with just a few months left until graduation and no plan. Then one morning, I got a call from someone offering me a job to start an emergency department pharmacy at the best pediatric hospital in the country. How did that happen? Well, earlier that year, I'd gone to a recruitment event at the Children's Hospital of Philadelphia, and, even though the prospect of working in pediatrics terrified me, I figured it'd be a good opportunity to visit a new city and practice interviewing. Well, during the tour, they took us to the ER, and they showed us the room that was to be the future site of the ER pharmacy. Now, the possibility of being a pharmacist in the ER was so exciting to me that I went on and on about it during my interview, and I even had the nerve to ask the directors for the job. Their response is what you'd expect when a P4 asks you something that ridiculous. But I must have said something right, because about 6 months later, I got the call offering me that job. And after almost 10 years in practice, I can't imagine working in any other specialty. And thank God another really great pharmacist was hired along with me to start that pharmacy, because that pharmacist became my wife. So this brings me to the last major turning point in my professional life, the one where I became a patient. A few months into my first job as a pharmacist, I began to feel experience some strange symptoms. I was falling asleep at work, I lost weight, I was insatiably thirsty, I was peeing every 10 minutes. And after experiencing worsening of these symptoms over a few weeks, it suddenly hit me. And my fears were confirmed when I saw the number 350 show up on the glucometer I was given to train on in pharmacy school. One of the first people I called for guidance after getting diagnosed was a friend, Peter Millen. Peter, who had lifelong diabetes, gave me some tips and basically just told me to suck it up. Well, 1 month later, my good friend and fellow Phi Delta Chi brother Peter died at the age of 24 from complications related to his diabetes. I'll admit that before this, I had been feeling pretty sorry about myself. And this shock changed my whole perspective. What did I have to complain about? Diagnosed as an adult, I had the training and expertise and resources to deal with this disease. Over the years, though, I've experienced the frustration and difficulty of living with a chronic disease. And seeing things from both the perspective of a patient and a provider, I realized how much work we needed to do if we were to improve our systems. So on a daily basis, I did my best. I tried to seek out unique ways to use my empathy to care for my patients, but it was frustrating because, honestly, I lacked the agency to change the system that I'd gradually become disillusioned with. But then my curiosity came to save the day. A few years ago, a colleague of mine introduced me to something called design thinking. He had taught a group of students about it, and he was trying to come up with new ideas to address medication reconciliation and medication adherence, two of the most complicated problems you could tackle. I thought he was crazy, and I was like, whatever you're trying to do is not going to work. But my curiosity got the best of me, and the more I was exposed to this new innovative way of thinking, the more I realized that there was a potential here to allow me to be creative again. Now, I'm not exaggerating when I say that design thinking has given me superpowers. So let me explain that in terms that my fellow geeks in the room will understand. In the movie The Matrix, Neo decides to take the red pill, and suddenly he was able to understand the reality behind his reality. Once he was able to see the code, how his world was designed, he became the designer. This is how I felt as I began to approach the world with this new designer's mindset. As you learn the skills and tools of creativity through design thinking, the world suddenly becomes malleable. Design has given me the creative agency and confidence to change my reality, and I've made it my new goal in life to help others in healthcare, from patients to providers, rediscover their own creativity. So, let's talk about design thinking in the terms of how we can apply it to advancing the profession of pharmacy. Despite what you see here, design thinking is more than just a couple of steps, because when practiced, it becomes a mindset that is ever present in your approach to solving problems. But everyone has to start somewhere, so it's best first practice in a series of 5 steps. Empathize, define, ideate, prototype, test. So let's start with the first step. Empathize with your users. Now, empathy is frequently misunderstood as a fluffy concept. However, empathizing with users is in fact a hard skill and one that everybody in healthcare should practice. Tools such as observation, interviewing, simulation, and landscape research allow us to step into the shoes of others, understand, and experience their reality. This assures that solutions actually meet a true need and are not based on our own assumptions. Now, this is the most important part of the design process, but also the most challenging because it takes great effort and diligence. Sometimes, however, it's not that hard. Gaining empathy means just getting out of your comfort zone and spending some time with somebody who has a completely different perspective. So on that note, let me introduce you to Lariq.
I am Rick Bird, 16. I was an honor roll student. I was a very good athlete, and I was a family-oriented person. Last December, I was shot at my C6, and I became a quadriplegic on event. A lot has changed because I lost mobility and most of my body and take for granted every day. Such as putting a shirt on, even sitting up by yourself. Stuff that you really wouldn't like second guess about, like really wouldn't think about losing in just a matter of seconds. Now my goals are just to get back to my regular routine. I will be returning to school. Like I'm just behind. Like, nothing really changed about me, just I lost mobility. My attitude to nothing hasn't changed.
The first half of this course, we were working on developing prosthetic devices using 3D printing technology. Once Lariq became a part of the class, the complete energy of the room changed. Suddenly, it wasn't that you were trying to solve a problem for somebody you never met, somebody you don't know. By having him here, it becomes personal. And that relatability means that you can design a better product.
You can move from this axis
If the room can design a better product.
Shoulder movement. That's great.
all these directions. And is it activated by shoulder movement? That's great.
It's very difficult to like change the channel and write and do stuff that I really used to actually enjoy, like play a game. I would like to be able to get back to that.
How'd that feel? Yeah, you like this one more? Yeah.
So, as you can see, empathizing with another individual truly is a transformative experience. And it changes everything about how you approach a problem when the patient, or the person the problem affects is right in the room. So, who are the users of pharmacy practice, and what can we learn from them? Well, the first and most obvious user group are patients. Some questions I would ask are, what is their story and what are their needs? How do they see us and experience the spectrum of pharmacy services and healthcare services as a whole? Where are the touch points and are we meeting them there? And where are we missing opportunities to provide care for, educate, and help both patients and their caregivers? Nextly, what about our non-pharmacy colleagues? What pressures do they face from their own profession? How do they see us? What benefit do we provide them and at what cost? What more can we be doing to help? I've never met another healthcare provider who doesn't appreciate the benefit pharmacists provide. Yet there still remains concerns and opposition to scope expansion. If we can begin to understand this perspective, we'll be better able to address these concerns. Now, unfortunately, I've heard more pharmacists question our own roles than those from any other profession. So the last user group we should talk about is ourselves. Our profession is so diverse, from the community to health system, pharma to managed care. How can we better understand each other so that we may work together on common goals? Even within a single focus area or a single institution, there is still so much we can learn. I'll admit that even with within my own health system, I have a little understanding of the day-to-day work of the perspectives of my own pharmacy colleagues who do everything from concierge medicine to investigational pharmacy. With such diversity, how can we be more cohesive? And what of the newest members of our profession? What do they see? Collaboration or competition? And how about those that are positioned to have the biggest impacts? Skilled pharmacy technicians. What are their perspectives? And how could we advance our mission together? Obviously, these three user groups are an oversimplification, but the key point is that solving any problem begins with learning who the problem affects. So next, define the problem. What's the problem? Or what do you assume the problem to be? What are its root causes? Do we really understand our users? And is our definition actionable? Problem definition is harder than it seems, especially in healthcare where wicked problems abound. The definition of a wicked problem is one that's so complex and dynamic that definition is elusive and no single solution can solve it. But we can approach this type of problem by breaking it down into actionable elements. So here are a couple tips. First off, make sure the problem you're addressing is the real problem. Consider reframing the problem from a different perspective. For example, does grandma need a new pill organizer or less pills? Very different problems, very different paths. 2, is your definition specific and actionable? Designers use the phrase, how might we, to frame the problem. So I'm going to ask you guys a question about 2 problem statements. So the first one is, how might we reduce childhood obesity in the United States? And the second is, how might we reduce childhood obesity in South Philadelphia public school children by increasing access to fresh food? Which one of these is specific and actionable? Second one, right? I can start thinking about how a single person can begin to address that second one, but the first one is so big, how do you even begin to approach it? Here's another one. How might we achieve national pharmacist provider status? Or how might we introduce state representatives to the benefit of pharmacist-led antimicrobial stewardship? Right? Any one person could do the second, but that first one seems like such an impossible task. The key here is that we are not simply announcing that we've identified a problem. The definition should begin to direct you down a path towards a solution while still being non-specific enough to allow for the exploration of innovative ideas. And this is why we use how might we, because it encourages action. This is also why having the right definition is so important, because you want to be sure you're solving for the real problem. Next, ideate on a solution. Now, overall, this is the fun part, unless you're a pharmacist. That's because pharmacists as a whole are insufferably pragmatic. I mean, we have to be. It's a core skill. But pragmatism and innovation don't really play nice. So that's why I love design so much. It helps me combat my pragmatic tendencies and rewards imagination. Do you think Steve Jobs looked at a picture of a rotary phone before designing the first iPhone? No, he started with a blank canvas. So if you want to ideate, ideation is best done in group brainstorms. So in brainstorming, you start with your problem definition, and then you come up with as many ideas as possible, allowing for the free flow of ideas that take you in a direction you may not have expected. There are some rules, though, to brainstorming. First, and number one, most important, defer your judgment. There are no bad ideas. Instead, encourage crazy ideas and build upon them. Even the craziest ideas can inspire something that can be truly transformative. 2, capture everything. Allow yourself to be visual. Use Post-its, draw something, even if you're terrible at drawing, it doesn't matter. 3, quantity over quality. Don't spend all day sitting there thinking about your one great idea. There's probably an even better one waiting to come out. So let the ideas flow. And 4, practice. Opening yourself up to creative thought may not come naturally, so practice by keeping Post-its handy, and how about challenging yourself to come up with as many ideas as possible in just a couple minutes when you're sitting around. So yes, it's hard to come up with crazy ideas, especially in healthcare where there's so many barriers and constraints that immediately come to mind. But if you begin with barriers, how can you really do something innovative? So let's practice. So this is a fun ideation exercise that you can do anytime with anybody. So the way it works is I'm going to start, and then the next person in the audience, whoever wants to go, should say yes and then build upon that idea. So we'll make it easy. So if I say, let's have a party, the next person might say, yes and I'll bring Jell-O shots. Okay, so who else wants to go? Just go ahead, free fire.
Yes and I'll bring music.
Awesome. Awesome. Come on, Mark.
Yes, and who's going to do the music?
I'll do the music.
Yes, and my people.
Okay. So yeah, so like keep it going and keep the energy up, and that's the whole point of something like this. It's just, it doesn't matter what you're talking about or, you know, what you're yes-anding. The idea is that suddenly you began to like stop being so quiet and you let your ideas get out, and that's a great exercise. So next time you're trying to solve a big, hairy problem, invite all of the users to the table, get Post-its, and have a brainstorm. Now, the next step is prototype your idea and test it. And this is something everyone in healthcare is terrified of. And it's attributed to our science-based education. The scientific method and the design method are diametrically opposed. This is because science focuses on understanding that which exists, and design focuses on creating that which does not yet exist. Science generally frowns upon failure, but design embraces failure. And to be truly creative, you must accept failure because nobody really creates the perfect thing in just one try. On the contrary, when caring for another human being, failure is really not an option. But the tension arises when we in healthcare apply that same overly cautious approach to decisions that are really not life and death. A favorite design saying is fail fast. And this is where prototyping and testing comes in. The goal of prototyping is to test an assumption or variable before investing too much time on a non-viable or suboptimal solution. The best example of this is in mobile application development. Most of you have probably said or heard somebody say, let's build an app for that. And then the conversation ends there because you don't think you have the skills to do it. Or worse, and unfortunately this has happened more times than it should ever, you build an entire application for months or years without ever checking to make sure the people you want to use it would actually use it. So a designer understands that that the first step is simply just asking your users if they would even use your proposed solution. And you don't need a 3D printer or programming experience to create a prototype. A good prototype can be low fidelity as long as it achieves its intended goal. Want to know if the buttons on your app make sense? You know, just stick a picture of your interface on a piece of cardboard and hand it to somebody. A simple prototype can save you a lot of frustration, but you have to be willing to show your work before it's complete. So, here's a great example of a simple yet effective prototype.
Music? This is possible dance moves for Monster Maker. So, music starts, and I'm the player, so I come in and I touch the monster, and he gives me a special dance move. I go and just a different one. And it can go for as long as I want. It has a few signature moves. And when I've had enough and I'm done dancing, I press the back button, pauses, and the music stops. Monster Maker.
Cool.
Right, so you can imagine if they would have spent months and months building the app before putting it in front of anybody, or they did that in like a few minutes, which is a big phone-shaped thing. So, you know, think about next time you're tackling a problem, what's the quickest way you can test out to make sure that, you know, what you're doing or the road you're going down is the right way? So when you design a prototype to test, think about the users, the variables, and assumptions surrounding your proposed concept. Break them apart and test the biggest assumptions first. Prototypes don't have to be physical things either. Maybe it's an experience that you act out like this, or even something as simple as a before and after picture. So how can we prototype and test the future of pharmacy? You know, maybe step one is just asking somebody what more we can be doing and then just trying it out. So lastly, iterate again and again. Don't be too quick to pat yourself on the back when you've gone through a design cycle. Good design requires iteration through many cycles of refinement through prototypes, reframes, tests, and user research. Think of iteration like versions of a piece of software that is always improving. As people use a technology that solves a need, it must change as the user's needs change. And as a technology continues to change and adapt to our needs, we as a profession must continue to adapt, and we have to adapt fast. I frequently hear a lot of talk about whether technology will make pharmacists and physicians obsolete. But you know who laughs at that idea? Nurses. Nurses are masters of both science and humanity. Remove the science and you leave the most important part, humanity. All of medicine was once this way, but we have gotten so focused on science and therefore metrics and therefore profit that it leaves little room for, we forget why people come to us in the first place. Today, we are sowing the seeds for our own obsolescence, not because we embrace technology, but because we focus on it to the point where we have little capacity left for human compassion. We must continue to iterate on our relationship with technology. Now, pharmacists are poised to strike this balance by continuing to reinforce our role as the most accessible and trusted healthcare professionals, while continuing to explore how technology can augment our work, leaving space for compassion in an increasingly complex healthcare landscape. Iteration is the soul of good design, never stopping, always reflecting, changing, and improving. Now, I'll admit that the design process can be very unsatisfying because in today's fast-paced and rapidly changing digital world, a design is never really complete. You work hard to create a beautiful thing, all the while understanding that it will be flawed, and you may need to spend a lifetime improving it. If you accept this reality, however, the real rewarding part of design becomes the creative process itself. Each small improvement can be celebrated as a step in the right direction, and through each iteration, you feed your curious mind and build your creative muscles, becoming an ever more proficient innovator. Even if there is no finish line, we can be happy knowing that we've learned from our failures and we've persevered. And this brings me back to where our conversation began, with curious and creative, the labels I cherish most today. Curiosity is a critical asset because it provides fuel for resilience. It keeps us from burning out or settling for the way things are and allows us to continue to use our creativity every day. The great scientist and designer Benjamin Franklin once said, "Hide not your talents, they for use were made. What's a sundial in the shade?" We all have the capacity to be both great scientists and designers. I see this most in our students, who are driven to create and follow their curiosity into exciting and unexpected territory. We all must continue to grow our talents, expand our horizons, challenge our labels, and create new ones. Then together, we will design the future of pharmacy. Thank you.